I'll start recording. So today we are going to talk about traumatic brain injury. Um, and it's going to be a quick overview of traumatic brain injury. This lecture series is going to try to kind of cover a lot of topics and, open to any topics that you guys have for suggestions. This specific one came from a case that I'd seen in Tanzania. It was a 5-year-old who had fallen off of a boda. He was seen in the casualty department at Celiani. He was presenting in extremis. His GCS was 8. His eyes were open only to painful stimulus. He was not making any verbal stimulus that made any sense. He was speaking, mumbling, and not Swahili. And he was withdrawing from pain, but not localizing the pain. The doctors and clinical officers in casualty noticed that he had a defect in his skull. His pupils were 4 millimeters when he showed up to the emergency department or to the casualty department. His heart rate was normal. His blood pressure was elevated for his age, and he was tachypneic. About 30 minutes into his arrival, he started having a seizure. I guess you guys can probably imagine seeing a case like this. It's not an infrequent case. I want you to think a little bit more about kind of what you would do at your local hospital. It might be different than what we would do, at certain locations. And just think a little bit about kind of how you would approach this case as we go through, okay? So the learning objectives is to just basically describe and define traumatic brain injury. Um, we also want to discuss the severities that exist in traumatic brain injury. We're going to talk a little bit about CT scans, although talking about CAT scans of the head and interpretation of the CAT scan can be its own lecture. So we're not going to do too much on that, but we are going to talk a little bit about it. And then we're going to talk a little bit about treatments and management of these conditions. The topic itself, traumatic brain injury, is basically structural injury to the brain. And this can result in two different ways. It can result in basically radiographic appearance. The CAT scan is probably the most helpful material or the most helpful method of diagnosing a traumatic brain injury, or it can be evident from exam. Um, and so anybody who basically injures their head and has an altered GCS or an altered mental status has a traumatic brain injury until proven otherwise. Any further kind of discussion about the nuances of it are totally valid. But for simplicity's sake, it's easy to just remember that traumatic brain injury is any neurological symptom after a head injury. And this can exist in a vast range of severities. And the way that we actually classify the severity is through the GCS. Um, there are 3 components to the GCS. We talk about eyes, we talk about verbal, we talk about movement. I'm sure you guys probably know this pretty well at this point, but this is just a reference in terms of how the GCS can be calculated. You're meant to add each score from each category and basically summarize the patient's mental status using a number. Now, the number doesn't completely summarize your exam, but it does give someone a lot of information with just one number. If I say that I had a patient who fell off a set of stairs and hit their head and their GCS was 15, that's to me, that as an ER doctor, that's much more reassuring story than if they fell down some stairs, they hit their head, and their GCS is now 6. So those are completely different scenarios just based off of one number. So it's a critical finding when you're talking about evaluating trauma. A lot of things can also go into obscuring a GCS, low blood pressure, intoxicants, pain can go into GCS as well. But generally, we use GCS as a survey, as a part of the primary survey to kind of basically gauge how severe a traumatic brain injury is. Now, the GCS calculates out to a number after you've used all 3 categories. Again, eyes, verbal, motor. Your severe GCS is classified as a GCS less than 8. It basically suggests that there is a severe brain injury at play. These patients usually have some degree of findings on their CT scan. They're usually described as either obtunded, stuporous, or comatose, all basically nuanced words that mean somewhat similar things, meaning that the patient isn't able to interact with you. They're usually unable to protect their airway, or they might be unable to breathe spontaneously because of their brain injury. This is the most severe type of traumatic brain injury, and the mortality for these conditions is usually pretty high. The moderate category basically is risk stratific is a group that can be kind of further risk stratified based off of nuance. Usually, these people will have some degree of injury noted on their CT scans, and it's a possibility that they do progress to severe TBIs, or they might make some degree of recovery, but it's hard to say based off of the moment. Any assessment that you have in time can change, and obviously GCS is essentially a vital sign. And so if you're assessing a patient at what moment in time, a moderate TBI can progress to a severe TBI, which is why it is an emergency. Moderate and severe TBIs are considered medical emergencies, trauma emergencies in the United States. And I think that having worked in Tanzania, you all would agree with me on that. A mild GCS or a mild TBI is anything with a GCS over 13. It's basically synonymous with a concussion. A concussion usually describes any neurological symptom that happens after a head injury, but a concussion doesn't necessarily imply that you have a moderate to severe TBI. It usually implies that you have a mild TBI. The most pronounced symptom usually for this is confusion. Their GCSs usually are around 14 for confused speech. Um, and just for reference, the confused speech just basically loses one command or one uh, 1 point for verbal. But it's otherwise something that isn't necessarily it doesn't necessarily cause other deficits in movement or eyes opening or whatnot. And this is basically what was stating earlier is that you want to remember that any assessment is at one moment in time, and you want to make sure that you take any assessment that you have with a grain of salt and understand that these can progress. And the way that we know how they progress is based off of the next set of guidelines that I'm going to show you guys. This might be new to most of you because it's relatively new in the United States. I would say it's probably only been around for about the last 18 months to 2 years that it's actually been widely accepted. It's called the Brain Injury Guidelines, or what we describe them as BIG, BIG. This includes the diagnoses that are made by CAT scan. So usually in the United States, we only actually scan patients who have either moderate or severe TBIs. And that's because we know that from a lot of research that they're not usually of much yield for patients who have mild TBIs. So usually we reserve CAT scans for patients with moderate to severe, and that further risk stratifies them into big classifications. So patients who are anticoagulated, patients who have epidural hematomas, patients who have any degree of intraventricular hemorrhage, patients who have skull fractures that are displaced, or patients who have large subdural or intraparenchymal or subarachnoid hemorrhages classify into big three. Now I'll show you guys some CT scans and we'll talk a little bit about kind of what that actually means, but that's a good summary of what a big three is. A big three usually results in a moderate to severe TBI, more likely severe. Usually, the treatment for a big classification is surgery. So, if you have patients that are anticoagulated or have epidural hematomas or any of the following, you want to make sure that these are discussed with neurosurgery. On the other hand, The big two classifications usually actually incorporate some degree of clinical judgment. And that includes an assessment of the patient's alcohol status. So if they're intoxicated, they can't meet classification for big one. If they have a non-displaced skull fracture, if they have a smaller subdural hematoma, or if they have a subarachnoid or intraparenchymal hemorrhage that is smaller. Now, smaller being basically a radiographic term. You can't diagnose any of these with your physical exam, and you certainly aren't going to be able to measure them, but you can measure them on the CT scan. And I'll show you how. The big two classification just basically usually warrants neurosurgery consultation, but it usually only requires observation. Now, the concern that we have about big two is that they progress to a big three, and if they do, then that's the reason that we want to watch them for at least 24 hours. We know from this patient cohort, from the studies performed in America and Europe, that if you watch them for at least 24 hours, they have a higher propensity to progress to a big three. So that's why we care about big two. In big one, basically all that goes away. And we say that if you have absence of any of the following characteristics that classify somebody into big two or big three, you only monitor them for 6 hours and you discharge them if their exam does not change. They When they were writing the papers, they had less concern that big one would progress to big two. And because of that, they thought that a shorter period of monitoring was warranted in a very small subset of patients that would get observed without any of these criteria. And by any, I mean any of the big three or any of the big two, that they would not necessarily be patients that would progress outside of the 6 hour window. The sensitivity for this was about 99.5%, depending on which paper you read. But the brain injury guidelines clearly outline that this is a very safe management strategy. Do you guys have any questions about that? Pretty
No,
simple.
it's quite clear.
Yeah, go ahead. Yeah, it's a pretty simple strategy that you could find on MD Calc and you can find online, and you can use it to determine. The only problem that makes it difficult is that in a resource limited setting, you have to be able to do it with CT, and you have to have a CT scanner readily available. The other thing is that if you classify someone as a big two or a big three, then you might need to be able to repeat the CAT scan to make sure that the blood isn't growing and starting to meet or declassify into a different category. So if you have somebody with a small subdural hematoma and you scan them after 12 hours and it's become a large subdural hematoma, then their management might change. And if their management changes, then the neurosurgeon usually will want to consider surgery for something like that. So those patients usually need to be in an area where they can be monitored and watched by a neurosurgeon. And just to clarify, big two and big three patients are almost always moderate to severe TBIs. The mild TBIs we know from literature don't usually need any of the large degree of workup that we provide for patients with big two or big three injuries. Hopefully that simplifies things a little bit and kind of opens up a little bit of the new evidence that we're using in the United States. And I use this basically not every day, but every day that I see a TBI, I use this to communicate with the neurosurgeons here in the United States. So moving on, let's talk a little bit about CT scans and how they kind of contribute to patient care. We already know that they're kind of essential for diagnosis and prognostication for acute brain injuries. Um, a little bit about kind of what we're looking for when we're looking at CT scans. The axial cut of the CT, this one here, basically outlines a normal head. And you can tell that it's normal because you can see the sulcation, you can see the gyration of the brain. You can also notice that there's differentiation of the white and gray matter, and we'll talk a little bit about why that's important. But those areas of the brain are basically essential when you're actually looking at the brain because you want to make sure that you can see where the white matter begins and where the gray matter ends. The sagittal brain gives you a good view of that as well. Here it's taken completely in the sagittal plane, so you're actually seeing the complete middle of the brain or the septum pellucidum, which also becomes important. The septum pellucidum is this part of the brain right here. It's a little flap of basically meninges that are folded over. The middle portion of the brain can be evaluated in the sagittal plane, and you can also see the brainstem, the pons right here, and then further down the medulla oblongata and even higher the midbrain. So this is a good place to kind of visualize basic anatomical structures. You're also seeing the basal cisterns and the ventricles as they sit within the brain, the third and fourth ventricle. In the coronal view, you're basically looking at the middle portion of the brain, the septum pellucidum. You can see the lateral ventricles, and you can also see the third ventricle here at the bottom. These structures are really important because when you talk about bleeding, the ventricles become a very important structural part to keep your eye on. And the basal cisterns are essential to evaluate for basically herniation. The skull base is also a really important structure, and right here we're looking at the foramen magnum, which is important when you're evaluating for herniation. Okay. Angiography and bone windows, these things are a little bit less important when you talk about TBI. I will say that it's worth knowing that when you see the brain basically blurred out like this, you can't tell, like in this window, where everything is, where the structures of the brain are, where the ventricles are, where the gray and white matter is. That's because this is really only made to be looking for the bone. And that's because you want to look at it in this window to basically evaluate for any fractures of the skull. Now you can take a look at any portion of the brain, the skull base, the coronal windows, through a bone window in order to figure out if there are any fracture lines. You also want to take a look real quick. Right here, we have basically sutures in the skull. It's a common mistake to identify them and think that they're fractures, but there are several sutures in the skull that are anatomically present in everybody, and you want to just make sure that you can see those. Angiography doesn't usually have a role in TBI. It's not something we readily recommend unless patients have a spontaneous bleed. So, let's move on to the next slide. And that's just basically an outline of normal brain. So what does an abnormal brain look like? There are like four types of basic radiographic TBIs that we'll talk about. A subdural hematoma, an epidural hematoma, a subarachnoid hematoma, and an intraparenchymal hematoma. The subdural hematomas are basically collections of blood outside the meninges. They happen from bridging veins, so they're a low pressure bleeding system. Epidural hematomas are arterial bleeds. They're a high pressure bleeding system. These are especially important, and these are almost never benign. These are almost always managed with surgery. And I'll show you the difference between the two because it can be easy to miss them. Um, I personally have misidentified subdural hematomas as epidural hematomas in the past, and vice versa as well. They can be easy to mix between each other. Subarachnoid and intraparenchymal hematomas are a little bit different, and they're a little bit easier to spot sometimes. Subarachnoid hemorrhages can be very subtle. They're also the most mild type. They usually are reclassified into the big one category. If you have only one area of subarachnoid hemorrhage, um, it usually means that there is not necessarily anything serious at play, and those usually classify into big one category. However, if you have two, that usually suggests a high mechanism injury, and those can progress. So you really want to be careful about subarachnoid hemorrhages when you have multiple. Intraparenchymal hemorrhages can be a wide posh of different things. It really depends on the mechanism. Usually we see these with really, really high mechanism motor vehicle collisions. So if somebody is cruising on the belt line or the bypass and they get into a really high velocity accident, you might see patients have multiple of these. These can be very, very serious, or they can be benign. However, I will say that usually this suggests a high mechanism of brain injury, and usually these patients have some structural damage to the brain beyond just what you're seeing on CT. These are not nearly as amenable to surgery, though, as epidural or subdural hematomas. So, a subdural hematoma, this is an example of a subdural hematoma here. This specific subdural hematoma I picked out on the images available to us, mostly because this is a chronic subdural hematoma. You can see that the blood looks dark. You can see that it collects basically along the brain. It doesn't cross, it does cross over the suture lines because the meninges are attached to the suture lines, but it's outside of the meninges, if that makes sense. As opposed to an epidural hematoma, which you can see here, this epidural hematoma, you can tell basically is abutted by two different areas. And I'll clear it just so that you can see it a little bit better. It's abutted by these two areas, and those are suture lines. That's because it's within the meninges. And so if you see it, I'm sorry, if it's outside the meninges, these are within the meninges. If you see it outside the meninges are basically anchored onto these areas, these red dots that I've placed. And the epidural hematoma can't go beyond them because it's captured within the actual pocket. Because it's such a high pressure system in such a small space, these can start compressing. You can tell that this one's already compressing on this side of the brain, and the midline structures are starting to move away from the actual bleed. That's pretty common with epidural hematomas, and it's why they're so dangerous. Intraparenchymal hematomas, on the other hand, tend to happen at the gray and white matter differentiation within the actual CT. You can see here that there's white matter, and you can see down here there's gray matter. You can tell that this bleed is happening just at that junction, and that's usually the case because this is a fragile area of the brain. So if you have a high enough mechanism that will cause shearing and bleeding within the actual parenchyma, it usually happens here. Subarachnoid hemorrhages basically happen kind of within the meninges and the subarachnoid space. This basically allows the blood to traverse every which way. It usually means they're usually caused by capillary bleeds, so they're not high pressure like epidural hematomas. If a subarachnoid hemorrhage occurs, it kind of spreads out throughout the sulci and gyri of the brain. You can see some dense blood right here and a little bit right here as well. Usually they kind of spread out a little bit, and they rarely ever cause midline shift in isolation. And that's just because they have a little bit more space to go, and they're usually not high pressure. These are high pressure, and these have as much space as possible. Subdurals have as much space as possible to actually cause compression on the brain, which is why these two are more dangerous and usually more amenable to surgery. So, if these become severe enough, how do you know when you need to be concerned? There are a couple different things. There's something called midline shift that I'm going to show you. There's also herniation, which I know all of you know about. There is ventricle effacement, and there's cortical abnormalities that we'll talk about as well. When you take a look at some of the brains here on this scan, they're obviously very abnormal. When you talk a little bit about evaluating for midline shift, you can tell the septum pellucidum that separates the lateral ventricles here is off to the side. When you talk about midline shift, any neurosurgeon's going to have expected you to basically draw a line between where the septum pellucidum starts and ends, and then evaluate how far the deviation is from the actual midline. Deviation more than 8 millimeters or I'm sorry, 6 millimeters is usually an indication for craniotomy. Herniation is a little bit different. Usually we want to take the patient's CT scan and we want to put it in the coronal position. We showed you a little bit earlier that there were a couple of structures that you want to see in the coronal view. You want to basically see the basal cisterns that are outlined here. You want to make sure that there's dark fluid around there and that you can see the third and fourth ventricle. If you have this circumstance, for instance, though, this suggests herniation because you cannot see any of the ventricles anymore. You cannot see the basal cisterns, and you can see there's downward pressure from the brain down into the brainstem through the foramen magnum, and that's causing herniation. Every part of this part of the brain that is being pushed up against the skull, this is all becoming ischemic, and they're basically having a massive stroke. That part of the brain is essential for basically every bodily function. And so you can imagine that if you have a stroke to every part of what's herniating through this foramen magnum, you're going to end up paralyzed and potentially dead, unable to breathe for yourself because of how much pressure is being caused on this area. Ventricle effacement is also a very poor prognostic situation. When you're talking about ventricle effacement, you're talking about basically loss of the ventricles. So over here with the patient with the midline shift, you can tell that the ventricles are basically preserved. Although this patient has significant midline shift here, you can still tell that the ventricles are present here and here. When you see a patient here, you can notice that there's so much significant pressure that it is causing a little bit of midline shift, but it is also taking out the entire lateral ventricle, which should be sitting right here where this second arrow is. If you can't see that ventricle, that basically presumes that the patient's going to become hydrocephalic and they're going to basically demonstrate obstructive physiology to their CSF. They're not going to be able to drain their CSF, and unless you correct the lesion, the actual blood clot, and evacuate it, the ventricle is going to clot, and the patient's going to have a very, very poor outcome. Cerebral edema, the last topic, is demonstrated here in the right left corner. And this can be a little bit subtle, but I'm sure that you can tell from some of the other CT scans how smooth the brain is. All these patients have cerebral edema to a certain degree, but you can tell in this specific one, there's loss of any sulcation or gyration in that part of the brain. You can't see any additional folds where you would otherwise see on this right side that I haven't highlighted. It's all basically pushed together. You also notice that the gray and the white matter has lost its ability to differentiate itself on the CT scan. It's become black, and you can't tell the difference between where the gray matter ends and the white matter begins. That's a really poor prognostic sign, and cerebral edema that's this severe will likely end up in a poor neurological outcome. If the patient in this circumstance has a lesion that would be amenable to drainage, a neurosurgeon would likely think very strongly about being able to evacuate it because this patient might die no matter the intervention. You'll also see this in some medical patients when you have high enough pressure cerebral edema. The most common, probably, at least in the United States, I don't know about in Tanzania, would be liver patients, cirrhotic patients. So that's a quick overview of the CAT scan. I want to talk a little bit about when to use the CAT scan. Um, we have some exclusion criteria that we use in the United States. I wanted to make sure that it was validated in sub-Saharan Africa before I presented it to you guys. I have seen that it's been validated across Africa and some parts of Southeast Asia. I couldn't find any specific studies in Tanzania or Kenya. But I will tell you that the PCARN criteria for children is something that is basically the standard of care in the United States. The exclusion criteria basically breaks down to two different things. It breaks the patient down into age. So if they're under or 2 years old, and then it creates three risk factors in each group. So in Kids who are over 2 years old, they need these categories in order to be able to, or they need these categories to be absent in order to be able to clear them from a high risk category. So if their GCS is less than 14, they likely need a CT scan. If there are any signs of the basilar skull fracture or their patient's presenting with objective altered mental status that you can appreciate on your exam, then they likely need a CT scan. The low risk category actually usually defaults to an observe category. And when we talk about observing the patient, I'm sorry I didn't write it here, but we're talking about observing them for 6 hours. Okay. So any history of loss of consciousness, any vomiting, any severe headache that the patient can describe to you, which I know is tough when the patient's over 2 years old, but you want to ask them if they have a headache, or any severe mechanism of injury. Now, the severe mechanism of injury is a little bit subjective, but you have to use your best judgment. If somebody falls down 10 stairs, I'm a little bit more concerned about them if they fall from a ground level, for instance. If they meet any of these criteria, they get observed, and you want to watch them for about 6 hours. If they don't have any risk factors, then you don't have to consider imaging. You can reassure the patient's family and you can discharge them. If they're under 2 years old, this patient cohort is a little bit more risky. You want to make sure that you take these patients a little bit more seriously than these patients that are older. So the younger patients are at a higher risk for clinical decompensation. The high risk category for them is again GCS 15, a palpable skull fracture, or any signs of basilar skull fracture that you could appreciate on a less than 2 year old, or if they're clinically altered, which can be extremely hard when they're less than 2 years old. If they have any of those, then you want to go right to CT. If they're low risk, however, you might appreciate a non-frontal scalp hematoma, i.e., a scalp hematoma that's over the occiput, the parietal, or the temporal scalp. If they have a loss of consciousness that's been over 5 seconds, if they're not acting normally per the parent, which is a subjective altered mental status, or you have a severe mechanism of injury, they fall a great deal of length, like a couple of meters, or they were in a very severe car accident, but they're acting normal. You want to observe those patients for 6 hours as well. If they don't have any of the criteria, then you can reassure the patients and you can discharge them. Or you can reassure the patient's family and discharge them. So that's a good clinical decision rule. They have to be less than 18 in order for you to use that rule. However, for adults, we use something different, something that came out of Canada called the Canadian CT head rule. The Canadian CT head rule basically implies that the patient has to be above 16 years, so you can use it for a 16-year-old if you wanted to. They cannot be on blood thinners, and they cannot have had a seizure after injury. Those are probably the most important things to remember about this imaging rule, because these basically imply each of not necessarily the 16-year-old, but the blood thinners and the seizure after the injury. These two things imply that they're very, very severe risk factors. So if they have either of those things, take any head trauma seriously. If they have any high risk criteria, assuming that they're not on blood thinners and they haven't had a seizure, any GCS that's less than 15, 2 hours after the injury, you want to consider a CT scan. If they have a suspected open or depressed skull fracture, which our child in the scenario did, if they have any signs of a basilar skull fracture, if they've had more than 2 episodes of vomiting, or if they're over 65 years old. These rules imply that you should at least consider CT. It doesn't mandate you to order the CT, but it makes you strongly consider. The incidence of intracranial hemorrhage in this group is still relatively low. It's meant to be a sensitive criteria. It's not meant to be a specific criteria. It's basically to help you not miss a traumatic brain injury. Medium risk criteria basically just assumes that the patient has had retrograde amnesia or a quote unquote dangerous mechanism. Now, in the papers of the Canadian CT head rule, they actually outline this. It's any mechanism that was auto versus pedestrian. So if they were hit by a car, that's a dangerous mechanism. If they were ejected from a vehicle, or if they fall from 3 feet or 5 stairs. 3 feet is about 1 meter. Then you want to also consider the imaging, but this cohort has a much less, a lower incidence of intracranial hemorrhage than this cohort. So that's basically a couple of rules of when to order CT scans. Does that all make sense? Good deal. All right,
Yes,
so
it does.
Yeah, it
great.
does.
When you talk about PCAR and you talk about the Canadian CT rule, do you need either of these to diagnose a TBI? Usually not. Usually a TBI can be diagnosed clinically. Now, I will say that outside of working with you all in Celiani or working in Tanzania in general, I usually practice with a CT scanner. So I don't have an issue with trying to get a CAT scan if I feel like I need to radiographically prove that they have trauma. That being said, if the patient has a GCS of less than 13, and I don't have any other reason to know why their GCS might be low, I'm usually thinking that they have a a se moderate to severe traumatic brain injury. And this neurological assessment basically has me concerned that they have a TBI until proven otherwise. The CT can basically confirm my suspicion, but usually in the States, I will say that if the patient is altered to this degree, I'm following them to the CAT scanner. I'm not letting them leave my site until I've proven to myself that they don't have a TBI. So this is a pretty strong clinical assessment, and it's something that I feel like if you get good at, you'll be able to actually determine the patient's prognosis and determine the patient's condition before you actually get the test. Management for TBIs can be very, very broad and very, very difficult sometimes. First, you want to make sure that you start with a primary survey. You want to make sure that their blood pressure, their heart rate, their respiratory status, and their temperature is all obtained. The reason why we want to know the blood pressure is we want to avoid hypertension. For that matter, we also want to avoid hypotension, and we want to make sure that the patient is normotensive. What that means is a little bit nuanced, and some of the guidelines differ in the United States, but I'll talk a little bit more about that. The heart rate is more generally included in the assessment. If the patient has a bradycardia, I want you to think that this might be an imminent sign of severe TBI, because it can also mean herniation. The reason why is because some people or some doctors back in the way, way long ago, the 20s, 30s, described something called the Cushing's triad. And the Cushing's triad basically includes apnea, bradycardia, and hypertension. If any two of these three is present, then I want you to really consider that they might have a herniation syndrome. It would be reasonable to consider actually using hypertonic in that situation, and I'll talk a little bit more about that. Included in the management, you also want to make sure that they have a blood glucose. Their blood sugar needs to be euglycemic. Now, I know you guys use a little bit different measures, and I'll make sure to try to do that in the future. But in the American standard, it's 110 to 180, which I think is about 8 to 13 in the Tanzanian units. And for non-diabetics, you want to make sure that it's between 80 and 110, which I think is I think it's 6 to 8, if that doesn't sound wrong. The most important thing about this, though, is to remember that the vital signs are extremely vital. You want to avoid fever, you want to avoid hypertension, you want to avoid hypotension, and you also want to assess for apnea. Any of the Cushing's triad, if at all present at any point in time, should make you very, very concerned that the patient is imminently herniating and that they have a severe TBI. These assessments are also to be used within the assessment for GCS. If a patient has, apnea or bradycardia, and they're able to talk to you and they're able to have a subsequent GCS of 14 or 15, then you should consider other issues that might be at play besides just traumatic brain injury. The treatment, and I tried to abbreviate this slide as much as possible. I've highlighted or I've bolded the most important issues. Hypertonic is probably the most mainstay thing that we want to talk about. Craniotomy is also the thing that we know prevents morbidity and mortality with these patients, and seizure medications. Blood pressure control is also important, but it's a little bit more nuanced. And you also, when you see a TBI patient, want to try to avoid steroids. It's actually the only level 1 recommendation out of American Academy of Neurosurgery guidelines that is recommended regarding the treatment of traumatic brain injuries. The first thing that I want you to do and remember, though, when you see these patients is to elevate the head of bed to 30 degrees. Now, it doesn't matter how many resources you have, whether or not you're out in the bush, or if you're in Celiani casualty, or if you're working at Muhimbili. You want to make sure that you elevate the head of the bed so that you can prevent any significant gravity at play and make sure that their intracranial pressure is most maximized. You want to make sure, though, that you do that to maintain T, L, and C spine precautions if they're not already cleared. So if you don't have a CT scanner and they have a high mechanism, what you can do is you can rest them in the recumbent position and basically make sure that you elevate the head of the bed like so that the patient maintains a normal T and L and C spine, but without actually sitting the bed up like this, because this would basically negate T and L spines and would bend the patient's back. So just something to consider. If you have a bed that can do this, then it's important to try to remember this method and not this method. Although this method is definitely more usually done for patients who have TBI. In regards to hypertonic, I will say that hypertonic medications should be reserved, if possible, when you have a CT scanner. This is what most American guidelines suggest. Hypertonic saline is usually preferred to mannitol. Now, I never saw hypertonic saline when I was in Tanzania. I think that mannitol is more readily available. Mannitol is totally fine. It's not something that should be avoided, but they do carry more risks than hypertonic. Hypertonic usually has a less side effect profile, and it's usually more tolerable. A quick word about blood pressure. Usually you want their systolic blood pressure less than 160 or 140, depending on kind of what literature you are looking at. And you want to use beta blockers or non-diphenhydramine calcium channel blockers. Those include nicardipine, nifedipine, or amlodipine, things of that sort. We already talked about avoiding steroids. We're not going to give these patients steroids. In addition, craniotomy. Craniotomy is very important for basically this cohort, the epidural hematoma cohort. It has a lot of role in subdural hematomas as well. If a patient has a subdural hematoma with substantial midline shift, then it's an absolute indication for a craniotomy. A neurosurgeon should never turn down an epidural hematoma or a subdural hematoma with 6 millimeters of midline shift for a craniotomy, because these patients are the patients that have the highest possibility of success with craniotomy. So craniotomy is specifically very good for these types of cohorts. A quick word on seizure. If they have seizures, levetiracetam or Keppra is usually the preferred agent. Phenytoin, which I know is more readily available in Tanzania and Celiani, has been shown to increase mortality slightly in some patient cohorts with traumatic brain injury. It's usually only reserved, the anti-seizure medications are usually only reserved in patients who have severe TBI. So if the patient has a GCS of less than 8, if they have an associated seizure with their TBI, or if the neurosurgeon has determined that there's an epileptogenic site at play. This is usually something that you shouldn't be deciding. It's something that should be decided by a neurosurgeon based off of their review of the CAT scan. So What is this patient's prognosis? The prognosis basically breaks up into two categories. They have acute prognoses, which is what you're concerned about when you deal with these patients in casualty, and they have chronic prognoses. The acute prognosis is definitely determined on how well you treat them and what their presenting GCS is. We care about acute prognoses because we can basically keep most patients alive with TBI. TBI is the most common cause of acute traumatic death in the United States. And it's usually because patients present late in their course or their TBIs are so severe and the time-sensitive manner through which they meet a neurosurgeon basically determines their acute outcome. So if I see a patient here where I work primarily in rural Wyoming, it might be a different outcome for the same patient with the same TBI because they can't get to a neurosurgeon within hours, as if somebody presents in the middle of New York City and they're right next to a hospital that has a neurosurgeon on call 24/7. Chronic prognoses are usually discussed via neurosurgeons and neurocritical care specialists. The chronic prognosis usually carries some degree of morbidity and mortality. They usually are ventilator dependent. They might be G-tube dependent, and they might require help for the rest of their lives. The chronic outcomes of these patients aren't necessarily something that you want to bridge until you've actually kept them alive through their acute management. The acute management is really what will save lives. The chronic management is something that needs to be discussed with the patient's family and the patient later on. So let's talk a little bit about resource limitations. We talked a little bit about this already, but if you don't have a CT scanner, you can still manage and prognosticate a TBI. And we're doing that through an assessment of GCS. Okay. The GCS is very, very helpful. You can't use the big guidelines if you don't have a CT scanner, but you can use this GCS to calculate your probability. So if anybody hits their head, I want you to immediately ask yourself, what is their GCS? Medications. I know that you all don't have readily available access to Keppra or hypertonic saline. I don't have much to offer to you in terms of suggestions in this regard. I know that levetiracetam on an international level is becoming more readily available. So hopefully this becomes more readily available with time. And I know that hypertonic saline is not as easy to keep as mannitol. I want you to remember that mannitol is a good medication, but it does have just a bit more side effects than hypertonic saline, which is more readily accepted as the standard in the United States and Europe. Now, probably the biggest resource limitation that each of us deals with is surgical. That's basically because a lot of us work at a hospital that doesn't have a neurosurgeon at it. I myself work primarily at a hospital that doesn't have a neurosurgeon on call. You got to remember that distance, time, and transport are very important prognostic factors and may affect a patient's outcome. This is something that we can't control or know, but it's worth knowing when you take care of these patients that if you're very far away from a neurosurgeon, i.e., there's not a neurosurgeon in Arusha, or you're taking care of somebody much more farther away, like Karagway or somewhere more rural, that they might end up having a bad outcome comparatively to somebody who gets injured just down the street from KCMC in Moshi. So the important considerations for all these patients, I'm sorry I didn't finish this sentence, but you want to make sure that you think about their mechanism. You also want to make sure that you evaluate the patient for herniation, and you want to make sure that you keep in mind the Cushing's triad. These patients are very, very sick. Again, Cushing's triad is apnea, it's hypertension, it's bradycardia. If you see any of those symptoms in somebody who has a moderate or severe TBI, I want you to immediately think of hypertonic saline or mannitol. I also want you to remember that, considering everything, it's really important to remember that these patients with severe TBI usually will have other injuries. I like to say in medicine, the most common missed diagnosis is the second diagnosis. If you can't fully evaluate a patient, that's okay. Take care of the big issue at first, but always remember that where one diagnosis is, there's usually a second diagnosis if this condition is severe enough. Um, Really quickly, there are new innovations happening in neurosurgery, and I know that this is actually happening more in Tanzania as well. There are surgical approaches that are changing. They're going to become more readily available, and they're going to become less invasive techniques that have been shown to prove better outcomes that become available to you guys soon. And there's also a lot of literature discussing, not specifically with Tanzania, but I did see that there are global health efforts to try to make hypertonic saline more readily available. Some people also suggest in resource limited settings that you can even use high concentrated bicarb in the setting of absence of hypertonic saline. Um, I don't know that I would recommend that because the limitations are quite sparse. And instead, I would probably recommend that you guys stick to what you know, which is mannitol. But this is becoming more readily accepted and it may become practice changing here soon. So the most important way to stop or to treat a TBI is to prevent a TBI. You want to make sure that you don't have you have some public safety, um, and that people are wearing their helmets. I know that's ridiculous. I rode on a Peaky, I rode on a Boda. I know that's a ridiculous thing to ask, but you want to make sure that people are riding with helmets when they're on bodas and when they're on Peakies. You want to make sure that people have good street safety, specifically seat belts. And you also want to carry with yourself a little bit of knowledge regarding the substance use is a high predilection and predictive value for putting someone at risk for a TBI. Alcohol and drug use kill a lot of people, but trauma is definitely something that attributes to both of these things. And if anybody uses alcohol or drugs, they certainly have a higher possibility of TBI. So the case that we talked about initially with the 5-year-old, if you take this case step by step, I want you to imagine that you're seeing that same case, 5-year-old who fell off of a boda, who's having a seizure in front of you. I want you to make sure that after the seizure, you're assessing their GCS, you're securing their airway, you're securing their breathing, you're securing their circulation. If their GCS is less than 8, I want you to consider the fact that you might need to secure their airway. A severe TBI usually ends up getting intubated. The head of bed should be elevated after their seizure. Make sure that their C-spine is protected. I want you to consider the fact that you would obtain a CT after doing only these 3 measures first, these bedside measures. You only get the CT scan after you've done the primary survey. And then you want to make sure that any treatment that comes might be titrated based off of the CT scan or your serial exams, whichever is basically more readily available. If you have the CT, you can use the CT to guide whether or not you're going to treat with levetiracetam, you're going to treat with mannitol, or you're going to treat with hypertonic saline. But you also want to make sure that whatever you're doing is in adjunct with either your pretest probability without the CT or based off of the CT scans themselves. And then obviously at some point you're going to want to discuss this case with neurosurgery and make sure that the patient gets to the care that they need in the most readily rapid way possible, right? Neurosurgeons are not always available, but they're going to be the experts when it comes to actually caring for these patients, and trying to get them on the phone is extremely important. So the next steps that we can take away from after this lecture, and we will talk about some of these things. I want your feedback in terms of what you'd want to know more about, but we should talk more about CT scans and how to interpret them. We have understood a little bit more that TBIs are emergencies and that they're time-sensitive conditions. And we also want to think a little bit more about barriers to transfer and how to transfer these patients safely and quickly. So a lot of that comes down to understanding your facility's abilities and understanding where you refer these patients to. summarizing and quickly ending this, I know I've gone a little bit over time. I apologize. TBIs are serious conditions, they're medical emergencies. GCS is paramount. It's the most important thing that you can take away from today. If you the next time you see a TBI patient, you want to make sure that you're doing a primary survey, but that you're absolutely making sure that you do your GCS assessment. Um, After your GCS and your primary survey are done, I want you to remember that vitals are really important. No patient should ever go to a CT scan without a set of vitals. The vitals can be readily corrected, and any patient who has a TBI should be normothermic. They should have an adequate respiratory rate, and blood pressure should be considered. The glucose is also a very important thing, and you need to check a glucose in these patients as well. The last thing is that we talked a little bit about moderate and severe TBIs. Moderate and severe TBIs are very serious conditions, and they require neurosurgery evaluation, and they're neurosurgical emergencies. So the next talk that we'll do, I had suggested the Dr. Ari Cassidy and maybe even Dr. Ari Clement. I'm not sure if we talked about this yet, but I was hoping that we could talk a little bit about abdominal pain next time. The next talk, if it works for you guys, is the next Saturday. I will throw out an email with the link, but we'll talk first on WhatsApp to make sure that those times work for you guys. So just expect me to loop back around. I will send a WhatsApp either later today or tomorrow, just confirming that this might work. And make sure that you tell your friends about these things. We want these to go out to as many people as possible, okay? The website up here, this one is going to be where we reposit the videos and where we reposit the PowerPoints. I'm going to make sure that you guys all have access to this. And if you guys want to, you can also send it to your friends so that they can review any of the videos that we end up accumulating. I'm sorry that we're only doing it monthly for now. I'm hoping that we'll be able to do it more frequently here soon. The last thing that I want you guys to have access to is just a little bit of ongoing reading material and ongoing lecture material, okay? So the things that I would actually recommend the most are probably specifically for this topic are Radiopedia, which is a repository of CT scans, and you can look up how to basically evaluate CT scans for certain conditions on this website. And then MDCalc. All the scoring systems that we had talked about regarding whether or not to order a CT scan, the brain injury guidelines, how to calculate a GCS, those are all available on MDCalc, and it's a really, really helpful little app. So if I can do anything for you guys today, and if there's anything that you can do to take away to continue your learning, I would definitely recommend to download this app. I'd also recommend to take a look at Radiopedia, especially if you're like Dr. Ari Clement and you want to get better at CT scans, and you want to interpret more CT scans. Radiopedia has a repository of a lot of different CT scans that you can trial cases, and you can actually even see feedback. I also included a bunch of links that you'll be able to access when I upload this onto KOPI's website that involve a couple of the topics that we've discussed. Basically, what do you do in a resource limited setting with a patient with a TBI? What specific things are being made in Africa that are trying to advance the care for these patients? And basically how you can do traumatic brain injury care without invasive monitoring, and there's a little bit of the brain injury guidelines as well down here. So you can take a look at some of this at your own leisure, and I welcome you to give me any feedback about the lecture. And if you guys feel like you want to talk about something else besides abdominal pain, we can do that. And I'm going to stop recording right now, and we will chat, and then I'll let you guys go because I know it's gone a little bit over the time. So what questions do you guys have?